Right. Okay. So good afternoon to you all. And also good evening, Dr. Senra and colleagues joining from Australia. And also at the same time, very good morning to all of you joining from Americas and the EU. So this is the first clinical webinar organized by SLVA and its webinar program during this COVID-19 period. And it's an absolutely pleasure to have all of these Sri Lankan vets live from different time zones of the world. So the session structure will be like this. There will be a first lecture of 1 to 1.5 hours, followed by a Q&A session. And during the Q&A session, you can ask live questions, and also during this lecture, you can text your messages if you want to this Zoom platform text message option, so that those questions will also be incorporated between the live questions. And also this program goes live in our YouTube channel of SLVA. You can subscribe to that and participate through YouTube channel also. And also I would like you to request to mute your microphones so that we can have an uninterrupted session lecture. And before we start the lecture, I would first like to invite Dr. Erandika Gunawadana, President SLVA, to welcome you and to address this virtual gathering. Dr. Erandika, please.
Yeah, thank you very much, Chandika. I think you can hear me, right, Chandika?
Yes.
It's audible, yeah. So welcome you all for this today's afternoon. And my dear colleagues who are joining here from the overseas and the local, through this Zoom platform, and my teachers and other senior veterinarians and practicing veterinarians in the field, and small animal practitioners, and all are welcome for this second webinar which we are conducting by the Sri Lanka Veterinary Association. And apart from the physical CPD workshops, we initially conducted one in Jaffna Medical Faculty for the Northern Province veterinarians, and the second one we conducted in the veterinary faculty under the for the small animal practitioners in the country by Dr. Chandika on dentistry. And so with this new normal situation in the country, and with this travel ban and this pandemic situation, we had to shift to this hybrid platforms to deliver our CPD programs. So we, as the SLV Exco, we just thought to give more opportunities for our local veterinarians rather than going for overseas specialists, to give them the opportunity to share their knowledge and the expertise with our fellow veterinarians. Maybe in the overseas also, you can compare their standards with your, standards in your overseas, veterinary professions. And meantime, we can give them the opportunity to build up confidence to deliver lectures and, these webinars. And later on, we can just make them icons in the country for particular fields of interest and the field of expertise. And then where they can, even the same way, they can deliver these lectures and webinars in the overseas forums also as well. So we made a calendar for this series of webinars by the XLVA. And I just request permission, 3 minutes permission from the chair to give some highlights and about the SLV activities. We were able to conduct the World Veterinary Day in the grand scale just before the third wave. And there we launched the platform for the media, to deliver our messages, our opinion for the general public from the SLVA. And from that platform, we were able to launch our first ever magazine through the SLVA, the Your Veterinarian magazine. And the first webinar was conducted for the authors to write their articles and improve their skills for the general public. And in the meantime, I invite you all also to write to our magazine. It's a quarterly published magazine, which will be a sustainable project launched by the SLVA. And meantime, we were able to launch the veterinary app, the mobile app, with the collaboration with Dialogue. It will be going under the MyDoc app in the country. So you can log into that app and deliver your services in great manner and for the general public. And meantime, you can earn some monetary values also. And our professional standards will be reach into greater heights in that way under this pandemic situation. And I invite you all to, we have, I think, emailed the details of this app through the Dialogue, and you can just contact them personally and get yourself registered. And then the media, the wet mobile app will be under your fingertips. After that, you can deliver your services through the clients in a standard manner. And meantime, we were able to get a great achievement from the government that for the first time, and we were declared as essential services in the country in the list of pandemic, the essential services declared by the government. So with the collaboration of the Director General in the department, and also the great help from the other sister organizations as well, we were able to convince the political pillars in the country how important the role of veterinarians were performing their duties under this pandemic situation. So we know, as the private sector veterinarians and other field veterinarians, we face with a lot of constraints and difficulties to travel to dispose their services under this pandemic situation with the travel ban. I think this will be lifted after this thing, and it's a great achievement for us. So with that insight, I'll invite Dr. Senura De Silva to conduct the webinar on the cardiology. We are going back to the basics today, and after that we can have more webinars to have the advanced cardiology. And meantime, we are going to organize the ultrasound scanning sessions also on cardiology with Dr. Senura. And I'll invite for this today's seminar. You all are warmly welcome today. Thank you very much.
Thank you very much, Dr. Erandika, President SLVA. Before the lecture, I would again want to remind the members who join now that this program is going to be telecast live through our YouTube channel. So if you want, you can join through YouTube also. And also a humble request to mute your microphones so that we can have an uninterrupted lecture. Please mute your microphones. And now I would invite Dr. Sugat Pemachandra, Secretary SLVA, to introduce our speaker today, Dr. Senura De Silva. Dr. Sugat, over to you.
Thank you very much, Dr. Chandika Vikramasinghe. Good evening to everyone. It's a pleasure to introduce Dr. Senura De Silva, our resource person today. He graduated from University of Peradeniya in 2015 with first class honor degree. He completed the National Veterinary Exam in 2018. I'm proud to say he is a member of the Australia and New Zealand College of Veterinary Scientists in small animal surgery. Currently, Dr. Senura De Silva is practicing as a general practitioner and emergency clinician in Victoria, Australia. He has a special focus on surgical oncology, TPLO surgery, treating canine cruciate ligament diseases, and abdominal ultrasonography. On behalf of Sri Lanka Veterinary Association, I would like to invite Dr. Senura De Silva to continue the program. Thank you.
Hello.
Yes, Dr. Senura.
Yeah, can you see the presentation?
Yes, doctor. We can see and we can hear you clearly.
Oh, wonderful. Thanks first of all for having me over. It's as you can see, I'm not a cardiology specialist, but I have worked with some cardiologists in Sydney Uni and in Melbourne as well. So before we start, like I said, I'm not a cardiology specialist. Information that is provided in this presentation have been from multiple sources and documentations, university lectures, etc. I would like it to be an interactive session with some questions and answers throughout the session. So if we've got the chat box working, so we can probably use that. Don't feel upset at asking any question. I would like it to be an interactive session, and if anybody requires a copy of the presentation, I'm more than happy to send it through to them. I love this picture that I've got here. Is it basically gives you the entirety or a refresher of what the heart is and what the valvular structures are, etc. I think So basically, the cardiac patient is what we see is of different sizes, shapes, breeds, etc. I see a lot of the smaller breed dogs. I see a lot of cats. I don't see a lot of Dobermans and boxers that is commonly seen in Sri Lanka. But so first of all, approaching a cardiac patient, so one that you suspect, one of the biggest things that people forget to remember is the signal that gives you a lot of the information that you need. As an example, you get the smaller breed dogs like your Cavalier King Charles Spaniels, your Malteses, your Shih Tzus. First thing that comes to mind when I look at them, and if I do suspect a heart disease, is like a mitral valve disease. Then you have your Dobermans, which are classical poster child for a good dilated cardiomyopathies. Boxers are a variable. You do get the boxer cardiomyopathy, which I'll discuss later in the lecture, and they're also commonly seen for dilated cardiomyopathy. And then you have your cats, which are commonly seen for congestive heart failure secondary to what we call as hypertrophic cardiomyopathy. The second most important thing is history. You'll know your typical lethargy, exercise intolerance, your dyspneas, syncope collapse episodes. I've put a question mark on coughing because when I was in uni and when I was a vet in Sri Lanka, it was a common thing to associate the coughing directly with cardiac patients. I'll touch on that, why I put a question mark in there. Clinical exam, you do your typical head to tail approach. You look at your gum color, your heart murmurs, which is a good indication, tachycardias, bradycardias, arrhythmias, and then you have your lung issues which related to your dyspneas, tachypneas, etc. Pulse is a good indication, especially when it comes to cats. Cardiac cachexia is more of the weight loss that is associated with heart disease. I see it a lot when I have a chronic heart patient that tends to lose weight. And then your typical ones that you see with congestive heart failure, your SITs, hepatomegaly, lymphedemas, which in my experience here is a lot less common. Auscultation plays a big role, and when it comes to cardiac auscultation, location is most important. So my go-to way of classifying them is as being cardiac apex versus cardiac base. Apex usually towards the fourth or fifth intercostal space, more towards the sternum at the bottom here, and then you have your the basal ones more towards the top. I always find it very difficult to say which one, whether it's the pulmonary valve or the aortic valve. I usually classify them as being a heart base murmur versus a cardiac apical murmur. And on the right side, you do have your tricuspid valve, which is neither basal or apical. It tends to be towards the middle of the heart. Clinically, heart sounds, there is two main types of heart sounds that you hear. The typical lub sounds, which is also known as the S1 heart sound. That's when your mitral valve and your tricuspid valve closures, that's usually in your ventricular systolic phase that you hear that. And then you have your DUP sound, which is the S2 sound, where you have your semilunar valves of the aortic and the pulmonary valves closure. So technically in the diastolic phase. So abnormal heart sounds are basically ones that you hear apart from the lubs and the dubs. So you do have what we call as the S3 heart sound, which is heard after the S2, as the name implies. So that happens when you have rapid passive ventricular filling, when the atria contracts, causing a rush of blood to come from your atria into the ventricles, commonly seen in conditions of congestive heart failure, mixed mitral valve disease, and severe hypertensive patients. Then you have your S4, usually at the end of the atrial emptying phase, and usually seen with the only time I've ever heard it is to be honest, is in the hypertrophic cardiomyopathy cats. That again, I don't worry too much on listening to the S3, S4 heart sounds, but if you can listen to them, that's quite fantastic. So a murmur, again, is basically an aberrant or extra sound that you hear. It's a bit of a humming or a buzz sound that you get, and usually found either, a lot of the the murmurs that I hear are basically between the lub and the dub sounds, but you can have ones that follow afterwards or just before. So basically, murmur classification is a good way of keeping records, and then you'll see why in the presentations to follow. I do classify my 1 to 2 murmurs as the very soft murmurs, where you kind of have to pay a little bit of attention to. I don't think I've ever classified any murmur as being a 1, because I don't think I have the best ears to listen to it. Grade 3 to 4 are your most common, which are easily audible. And a good evaluation is it'll be as loud as the dub sound, which is the second sound. 5 to 6 murmurs are hard to miss. They're quite loud, and technically you're supposed to be able to hear grade 6 hard murmurs without a stethoscope. One thing that is commonly misconstrued is that the intensity of the murmur is equal to the degree of heart disease. Yes, it can be used as a measure of progression of heart disease, but it does not equal to the degree of heart disease that's going on. So the fourth kind of a important area is your diagnostics. I do like a set of 3-view chest x-rays. How often do I do it? Not all the time, but my minimum would include a DV x-ray and a right-sided x-ray. Additional, I would like to have a left-sided and a VD x-ray as well. ECG, I don't tend to use it a lot, but it can provide a lot of information. A lot of times when I do use ECGs is in really severe congestive heart failure patients or in an emergency. Blood pressure monitoring, quite crucial, especially when treating patients. And finally, echocardiogram plus or minus abdominal ultrasound, depending on the cause. Again, echocardiogram, I do a decent amount of it, but not as much as I should, I think. So I thought we'll go through a bit of a case-based approach into the lecture. The first case that I have is an 8-year-old male-neutered Cavalier King Charles Spaniels. I'm not sure whether they are in Sri Lanka, but imagine that them being like a multi or a small breed dog. So when I first saw this patient a couple of years ago, it was a very soft left apical murmur. I hadn't noted down what the murmur was, so it's likely 1 or 2. So murmur had progressed to a grade 3 out of a 6 left apical murmur at a vaccination consultation that I had routinely, and on the rest of the clinical exam. Quite bright and happy. Capillary refill time was 1 to 2 seconds. Heart rate was a good 120. Small breed dog, so that's fine. Respirate was a happy 18 respirations per minute. The first question that I kind of would have for you guys is, if this was your patient, you know that your murmur has increased from a soft to a grade 3, which is a significant jump. What investigations would you do? Is there a way to get people answering on the chat? So you can either write A, B, C, D, E. I'll give about half a minute if everybody would like to participate. Got an A, echocardiography, got C. A and C. Anyone else? I think there's about 55. You would do all. Okay, so I think there's a lot of C's. There's an E, A, and C. Good, but let's see what I did. Or what I would do is either I wouldn't do anything, or I would go into radiographs. Why wouldn't I not go into investigations? It's more so because the dog was pretty happy otherwise. There was nothing that I could see to indicate that I should worry. The dog was breathing happy. There was no history of lethargy, exercise intolerance, so I could have easily gone with no investigations needed. But a good option would have been C, to do thoracic radiographs, and I'll explain you why I think I should have done that. But what I did do was I didn't do anything. The next question being, what do you think is the most likely cause for this murmur? It's a small breed dog. It has a left apical murmur. If people would like to have a try at answering. I'll give about half a minute. No one? Yep, we've got one MMBD, valvular failure. Let's be specific, like what valve would you be worried about? It's the left side, apical, murmur, systolic. Okay, so yeah, like I would be worried about mitral valve disease, mitral valve insufficiency, or properly named myxomatous mitral valve disease, kind of fits the bill. What is the pathophysiology of mitral valve? What's the cause of the murmur? Basically what happens is, I hope you can see the cursor where I'm pointing towards. Basically your ventricles during your systolic, ventricular systolic phase, instead of it going through the aorta, it pushes back through the mitral valves back into your left atrium. That's the entirety of the process. You have inadequately developed mitral valve that causes leakages, and that fluttering of the mitral valve is what you hear as a murmur. I do have a video here, and I hope you guys see it. And so if you look carefully, you can see on the echocardiogram, the left atrium is the smaller one on the side. Can someone confirm whether you guys can see my cursor where I'm pointing?
Yes, we can see, Dr.
Yeah, okay. So basically that's your left atrium there. That's your left ventricle. I've got Doppler ultrasonography echocardiogram on it. And you can see, if you look very carefully, the valve is fluttering in the wind there. Every time the ventricle contracts, I'll slow it down so you can see it better. So that's your left atrium contracting, going towards the ventricle, and now the ventricle is contracting, and you can see blood rushing back towards the left atrium. And if you look carefully where the valves close, I'll stop it again. So you can see, if you look carefully where the mitral valve is, there's actually a smaller gap, and that's your mitral valve insufficiency in patients. All right, moving on. By the way, if you have any questions during the process, just put it on the chat, and I'll happy to answer. So basically, following through the pathophysiology, you have chronic mitral valve regurgitation. That's basically what happens. Goes towards an increase in the regurgitated fraction. Basically what that means is it pushes more blood back into the left atrium rather than pushing it out into your general circulation. And because of that, you're going to have, your reduced blood pressure and basically poor perfusion to the organs. Your general compensatory mechanisms are twofold. You do have what we call as cardiac compensations, and then you have your non-cardiogenic compensations. Cardiac compensation is what you a lot of the time see when you do x-rays and echocardiograms. If you look, a normal heart has your left atrium, your left ventricles are nice and thick, and you have a nice thick wall here. Over time, the left atrium enlarges. That's the first thing that I notice in these patients. And over time, with volume overload, you do have the left ventricle enlarging. And what you notice here is that the muscles thins out and extends out through the entirety of the left ventricle there. And on echocardiogram, you do notice this enlarged left atrium right there with your left auricle that's quite enlarged, and thinned out left ventricle here, and the left ventricular cavity that's quite enlarged. How would thoracic radiographs help in this case? Good question. I'll come to that. I do actually have some x-rays. I'll show you what I look for and what you can identify. And I'll explain why I should have done x-rays as well on this patient. Non-cardiogenic compensations are basically twofold, and it's usually related to neuroendocrine response. What is related to the sympathetic reflex activation. Vasoconstriction, purely because your blood pressure goes down, your body's response is to constrict the peripheral vessels, so you have the blood pressure maintaining, and tachycardia, basically increasing the heart rate to push more blood into your rest of the organs. Problem with heart disease is it's a bit of a vicious cycle that happens. You start off with having a low cardiac output because some of the blood goes back into your left atrium instead of going out, and then you activate your compensatory mechanisms. Sympathetic activity does your vasoconstrictions and increasing the heart rate, which is your tachycardia. The renin-angiotensin-aldosterone systems, which is kidney related, if you can remember from your physiology notes, gets activated, and what that does is it tends to retain more fluids in the abdomen, in the body, and the body releases ADH or antidiuretic hormone, which again tries to keep more fluids in. So with this, you have your excessive vasoconstriction and sodium and water retention, which increases your preload and afterload. Preload is basically what the amount of blood that is in your ventricle before constriction, and afterload is the amount of blood that is remaining in your ventricles after systolic contraction. And then, when those increases, it just worsens your heart failure, decreases your cardiac output, and it just goes in the cycle and cycle. It's the purpose of heart disease and heart treatment is how soon you address and what you address to fix this mechanism. So everything that I discussed here on out is basically looking back at in which areas, how can I interrupt this vicious cycle. What I do, and I don't think it's done quite commonly in Sri Lanka, is stage heart diseases. Basically, the recommended, the Veterinary Cardiac Association has stage heart disease into 4 big stages. Stage A are patients that are high risk of heart disease, so your Cavalier King Charles Spaniels or your Maltese Shih Tzus who are prone to mitral valve disease, and you have your Dobermans for DCM, etc. Stage B is when you actually start noticing the first sign of some kind of heart disease starting, which is a murmur. But stage B, you don't see signs of heart failure, which relates to congestive heart failure signs. The stage B is further broken down into stage B1 and B2, which is quite important. B1 is where you only hear a murmur, but you don't notice any signs of cardiac enlargement. They mention only X-ray here, but also in echocardiogram as well. Stage B2 is where you hear a murmur, you don't see signs of heart failure, but you do see changes of X-ray. Stage C is, as an emergency clinician, where I see most of the patients coming into me, where there is evidence of heart failure and treatment is needed. Stage D, again, they're the ones that are in a severe state where I can't really intervene, do much to help. Moving on, so this is basically a simplified classification that I'll start using. Your stage A is your typical breed. B1 is you hear a murmur, don't see much signs. B2, you'll see an enlargement, you start worrying. C and D are the ones that are getting oxygen, and D, sadly, where nothing much that can be done to save them from heart disease. So coming back to the case one, we've kind of answered that questions. I've mentioned that I didn't do any investigations at the time, but I should have done thoracic radiographs, and this is more explaining as to why. So coming back to that question of what's been asked. So one thing that you have to do with chest x-rays is know your normal anatomy. This is a right lateral x-ray. You do have your caudal vena cava, which is a good position of where your heart should look, rather. Or caudal vena cava is very mobile, so if you see heart enlargement, you'll notice that the caudal vena cava moves around a little bit. Then you have your left ventricle, then you have your right ventricle here. Cranial vena cava, I almost never see it unless I look really hard. Then you have your left atrium where your trachea comes and bifurcates, and then you almost always see the aorta going backwards. This is a bit of a complicated view of a DV X-ray, but the most common area that I look for is the rounded left atrium here, where it's not a bit clear on this X-ray, but I'll show you on the other ones where your trachea comes and bifurcates along it. Then you have your left ventricle here, caudal vena cava at the bottom here, right ventricle, etc. Don't worry too much about these aortic arches, etc. Okay, so now this is the X-ray of the patient that was done later on. What are things that you can see on this X-ray if people would like to type in? So again, I see my caudal vena cava here, the aorta here, the trachea there and bifurcating. You have your left ventricle, right ventricle there. What is something obvious that I haven't pointed out that people could see if you look close enough? Anyone? Give about another half a minute. Yeah, Dr. Chandik is right on point. You do see this slight enlargement of the left atrium. Cardiomegaly, there is slightly, and I'll show it to you on the other image. Your VH is slightly enlarged, but even though it's 11.3, where your normal reference range is about 8.7 to 10.5, this breed Cavaliers, their chest is slightly smaller and they're slightly longer. This 11.3, I wouldn't be too worried about cardiac enlargement. So left atrial enlargement definitely is something that you would see. Pulmonary edema. Actually, no, I don't see if you look at where my pointer cursor is showing, where you have your fourth rib, it's not really enlarged on that. Left atrial hypertrophy, that's right. Good. This is a right parasternal short axis view that was done on this patient. And sorry, I say this patient, but this is actually a different case, but I'll show you. So this basically, a right parasternal short axis view, I think one of the other vets is going to discuss later on in the lecture series. But what I'm more focused on is the diameter ratio between your left atrium and your aorta. And you get the ratio right here, which is 1.43. It's less than 1.6, which is your cutoff mark. The fact that it's less than 1.43 tells me that the cardiac enlargement or the left atrial enlargement is not as significant. Okay, so case one, coming back to you, what other investigations would you do and what would your treatment be? Is there anything else that you want to do with this patient? Anyone? All right, you can send me the answers, but I'll go on. So like I say, what did I do with this patient at the time? I actually didn't do much. But this is where my mindset has changed from when I was this was 3-4 years ago to now. So there was this fantastic study called the EPIC study, or evaluation of pimobendan in dogs with cardiomegaly, that was finished probably about 2.5 years ago, if I'm not too mistaken. It is the largest veterinary cardiology study that's done in history. The main goal was to see whether early use of pimobendan can be used to delay the onset of congestive heart failure. So treatment until the end of this study, even among the cardiologists, was we'll just wait and monitor until the signs of congestive heart failure comes. But then they did this study where they actually evaluated for quite some time to see whether pimobendan as a drug could help delay the onset of congestive heart failure. And the results were quite astonishing. They noticed a 15-month delay in the time of extra 15 months of survival rate, 60% more time in asymptomatic stage B2 of heart disease, and that a lot of these patients actually got about 10% or more extra life. This study was quite significant that they had to call off the blind studies quite early on because it was getting to a point where it was quite sad, where if they didn't use treatment, it was not unethical to not treat the patients. So dogs who received pimobendan experienced a 15-month delay in onset of clinical signs of congestive heart failure and cardiac-related death or euthanasia, versus the placebo group, which didn't receive pimobendan. They just, I think, got a vitamin pill instead. So the case presented, the case presented 2 years later for a cough. And this is where I kind of want to change our perspective of what people understand about cough and cardiac related disease. The dog was still quite bright and happy. Heart rate was a good 128 minutes. The heart murmur has progressed from a 3 to a 4, still left atypical systolic murmur. The respiratory rate was about 26 beats per minute. I wasn't the one who saw the patient at the time, and the consulting vet noted a particular arrhythmia. And I do have a copy of the ECG that they did. Can anyone identify what this arrhythmia, she was a new grad vet, so can anybody identify what the arrhythmia is that they noticed? You have your P waves, your QRS and T waves. You can clearly see some are close together, some are wide apart. No one? I'm sure someone can guess. Yeah. Dr. Chandrika, being the cardiologist himself, answering the questions. Yeah, it is a sinus arrhythmia, which is affected by your respiration. So when you have taken inspiratory breath, it stops your vagal response. So you have your beats quite close together, and when they breathe out, the vagus response starts, and it kind of inhibits the heart rate, increasing the space between your QRS complexes. Yes, so it was a sinus arrhythmia. All right. So sorry, the same vet, being worried herself, being the new grad, did do some x-rays. What has changed from the previous x-ray to now? Can anyone notice? What can you see that's different to the previous set of x-rays? Yeah, there's definitely cardiomegaly, there's definitely tracheal elevation. You can see it's almost parallel to the vertebral column. Cardiomegaly, definitely. I think the VHS I mentioned there is about 12.8. Yeah, what else? Worsening of the left atrial enlargement, good, because you can see it's quite prominent. It's not just peaking anymore. I think the left ventricle is showing certain signs of changement there as well, and even the right ventricle, touching more of the sternum at the bottom. Right atrium a little bit enlarged as well. Can anyone see any pulmonary changes at all? Yes or no? I'll show you the next x-ray, which is better view of pulmonary. Sorry about the x-ray quality. It's hard to copy this, but can anyone see any obvious pulmonary changes? No. Yeah, okay, so going on, I really don't see any pulmonary changes. I do, again, you can see your left ventricle is quite enlarged. Left atrium's enlarged because you do see this cowboy-legged pattern that's there. Right ventricle, this is not the best positioned x-ray, but the right ventricle is enlarged there as well. Okay, so what acute treatment would you consider? The dog came in for a cough, that was a complaint. Dog's otherwise bright and happy, respiratory rate's about 28 beats a minute. What would you go as treatment? You can either put 1, 2, 3, 4, 5, 6, or select a few combinations if you'd like. 1 and 2, pimobendan, furosemide, okay. Who else? 1 and 4, monitor respiration, okay. 2, furosemide trial, sorry, pimobendan, 1 and 4, good. 2. Again, focusing on acute treatment, not chronic long-term treatment. What would you address? What would you do to address the cough? 2 and 3. I'll give about another 10 seconds if people would like to answer. So nobody agrees with prednisolone antibiotics. Okay, so I'll tell you why 1 and 5. Okay, pimobendan, prednisolone. Okay, so moving on. My treatment focus were more towards the last 3, and I'll explain to you why. Again, this is more focused on acute treatment, not long-term management on pimobendan. Pimobendan is a right answer because of the ethics study that I explained before, but I was more focusing on the acute treatment. But yes, pimobendan, long-term management, better outcome. Pimobendan is definitely an addition that I would have done in this case. But my focus on this was to address the cough and know why the cough was happening. If you do have a respiratory rate of under 30 minutes, and my patient was already in the clinic and had only about 28, there is a very, very minimal chance that there is signs of congestive heart failure. Patients that have congestive heart failure almost always shows quite a high tachypnea, dyspnea rate, which I didn't see with this patient. It was a cough that he presented for, and the fact that my respiratory rate was under 30 minutes, I would have completely ignored worrying about congestive heart failure. So going back, that's where I didn't worry too much on the furosemide trial. So, if you do have a patient that comes for a cough, first thing, think, okay, do your x-rays. Is there signs of congestive heart failure? Or first of all, is there signs of cardiomegaly? Okay. If there is, then you look at your pulmonary vessels. If I go back, again, not the best. Maybe I'll show it you on a different x-ray. Then you look at your pulmonary vessels. Are they enlarged compared to your rib structures? And number 3, do you see your interstitial alveolar patterns? I didn't see any signs of the interstitial alveolar patterns, and my respiratory rate is fantastic. So very, very low chance that it's going to be congestive heart failure. So my go-to treatment protocol with these cases is, if it's under 30 minutes, let's not worry about it. If the resting respiratory rate has been consistently above 30 minutes, there is definitely an indication for the furosemide trial. So usually try them a couple of days on furosemide, roughly 2 to 4 mg per kg. If the resting respiratory rate reduces to below 30 minutes afterwards, then that kind of confirms congestive heart failure. If it doesn't respond, you have to take radiographs again, see whether there is any other possibility of any other respiratory issue going on. I do have the advantages of doing bronchoscopy, bronchoalveolar larges, and with bronchoscopy guided, but you guys can definitely do blind BALs, which are quite easy, and I commonly do blind BALs or bronchoscopy guided BALs. So what was my acute treatment in these cases? The antibiotics is more of a choice of the long-standing acute nature, or rather long-standing chronic nature of the disease. A lot of the patients that do struggle with these diseases tend to have some degree of inflammatory and infectious process going on. So if their respiratory rate is normal, I would initially probably just go into antibiotic trials. My go-to is doxycycline, usually slightly at a higher dose than what you would use normally. I go at about 10 milligrams per kilogram twice a day. But you can also use enrofloxacin and cephalexins at these higher doses. Amoxiclav sadly doesn't have the best penetration into your lung cavities. So how I do an antibiotic trial is I usually prescribe for a week. If it responds, then I go long-term up to about 5 to 6 weeks. Because stuff like kennel cough, etc., can cause this type of coughs that are long-standing, that causes irritation to these dogs. When do I reach towards prednisolone? There is, quite a controversial versus beneficial argument when it comes to the use of prednisolone. I usually reach my prednisolone when I do notice my antibiotics alone aren't helping. Something that you have to remember, especially when I use doxycycline, is doxycycline also has an anti-inflammatory property to itself. So if it does respond to doxycycline, I'm more than happy to just use it long term. But if it's a prednisolone, you can go with 0.5 mg per kg twice a day, and then up to 4 weeks, I taper the doses over 4 weeks. There is enough evidence to show that at anti-inflammatory doses, prednisolone has no effect on worsening heart disease. So if you are quite concerned about the cough, if you want the anti-inflammatory effect, don't hesitate to use, especially when your patient is not showing signs of congestive heart failure. By the way, if there's any questions, don't hesitate to ask. So basically, this patient did respond to doxycycline alone, and the patient was quite happy afterwards. All right, let's go to a second case. So this is Dirk. Any cough syrups? I'm not too familiar with the cough syrups that's available in Sri Lanka. I've kind of lost my touch. I think a lot of the cough syrups that's available there are Benadryl or like antihistamine approach, and then more of soothing effect related ones. Those actually don't have much of an effect on coughs that are very much down the track. So this doggy's cough was very much more distal airway related coughs. It didn't have a TST positive or anything like that. So I should have mentioned that, sorry. So I don't really believe in cough syrups. I'll explain to you, like, I think it's this case, I'll explain to you what medication that I commonly use if I want to suppress cough. All right, coming back to case 2, Dirk. It's a good 11-year-old female. It's a Dachshund, long-haired Dachshund cross. Presenting problem again was struggling to breathe and coughing. Respiratory rate was quite high, so tachypneic 104 respirations a minute. Heart rate was quite high again, tachycardic 180 a minute. And this one had a grade 5, which was quite significant, of a left systolic apical murmur, short rapid breaths, crackling and wheezing lung sounds. All right, so would you suspect heart failure? And if yes, which side? 1, 2, 3, or 4? Again, sorry, the abdomen was fine, no signs of ascites, no signs of hepatomegaly, no signs of lymphedema. Would you suspect heart failure in this case? So we can answer 1, 2, 3, or 4. Yes, left-sided, good. 1 or 4, both left-sided and right-sided. 2, right-sided. 4, both left and right. Okay, so yeah, this patient definitely has signs of heart failure. Going back, age looks like it's a Dachshund, massive murmur, respiratory rate is high. There's dyspnea, heart rate's high, short rapid breaths, you have crackling and wheezing lungs. Yes, if you didn't think this patient had heart failure, it's a big mistake and you'll be missing out on a lot. Which side? I can only confirmatively say that it's left-sided. Can I say that it's right-sided? I don't clinically see signs to say it's right-sided at this time. So I would mainly be focused on worrying about the left-sided heart failure. All right, so this is the X-ray of the patient. What do you see? So pretty much similar to before, you have your left atrial enlargement coming all the way there, quite pushing outwards. Then you have your left ventricular enlargement. Then you have your right ventricle, which is massively enlarged. And then you have your right atrium there. If you follow my cursor, you'll notice the right atrium. You have your trachea that's supposed to head towards where the caudal vena cava is. It's more elevated upwards. And there's one thing that I see here. Can anybody notice something else that I haven't mentioned? Pulmonary effusion. It does look like it. That's true. That's right. Because you can see your cranial lobes not affected. Your Chordodorsal lobes affected. So that's good. Good answer. What else do you see? Does anybody see something else? I'll show you the next X-ray as well. No? Okay. I'll come back to this X-ray. Is it left-sided failure leading to right-sided failure too? It's left-sided heart disease leading to right-sided heart disease at the moment. There is left-sided failure because you do see congestive heart failure signs, or rather, no, sorry, my mistake. It's left-sided heart failure signs where you see the pulmonary effusion going on. But like I said, your liver, if you look carefully, that's your pyloric outflow, which is pretty much along with the ribs. So your liver is usually the first area that you would see enlargement if it is right-sided related. One other area that I look for is the caudal vena cava, but in this case, it's not clearly visible. So it's actually, we're in left-sided failure, left-sided disease, and right-sided disease, not in right-sided failure. This is the DV X-ray. Oops. This is the DV X-ray. You can again see that there is definitely signs of pulmonary congestion going on, more of an interstitial pattern going on there. All right. So where in this would you classify the dog? Is it A, B1, B2, C, or D? Let's see the answers. C or D? C or D, yeah. I would actually be specific to call it C because I haven't tried treatment to call it D yet. So this is the first time that the dog's presented. And so I would definitely just call it C at this time. Good, very good. All right, so that's basically coming to the explanation. There is evidence of heart disease, failure is visible, and treatment is necessary. All right, what is the emergency treatment? First thing that people would do. You have a dog who's struggling to breathe. What is the first thing that you do? All right, oxygen. So these are usually my go-to, go-to approaches. If it's mask, I do have them on very high flow, 5 to 15 liters per minute. I never go 15, it'll burst my oxygen delivery system. Oxygen cages is very commonly that I use. You can make them up quite easily. Nasal catheters, I used to use them often, not as much now, but there is definitely areas where I use it. Modified e-collars is a good way of doing this. Something that you don't see in this one is you basically have a thin cling film that you use to wrap food and stuff like that in, and then you pass a what you call oxygen tube into that. So if you have very limited space, if you want to get oxygen in, if your dog is not handling an oxygen case or a mask, that's one way of delivering oxygen as well. Second, what would you use? Second set of treatment as your emergency treatment. So we do have signs of pulmonary edema. There is signs of congestive disease that's going on. Very good. Yeah, furosemide. I use loop diuretic. Furosemide is the only loop diuretic that you need to use. I almost always try to get an intravenous catheter in. Once you give it, the peak effect is about 30 minutes. So the first 30 minutes, you have to supplement them good with oxygen before you start noticing any signs of improvement. IV effect is usually short durations, but you can start them on oral as well if you're struggling to. But the per os that I mentioned here is more that you have to remember for long-term chronic treatment. There's certain side effects that you have to worry about when you use furosemide. There is a sign of dehydration risk. It does activate your renin-angiotensin-aldosterone system because it reduces your sodium and fluid levels. So sympathetic system activation is something that you have to worry about. Electrolyte disturbances because it likes to push the potassium out quite easily. Treatment, I usually, depending again on the case, but I usually start them all with 2 mg per kg, bolus IV or intramuscular. There was a recent study that showed that intravenous or IM absorbance is pretty much on par, where you do reach peak effects in about 30 minutes. So if you are struggling to get an intravenous in, get an IM dose, and I usually repeat them quite regularly, every 2 to 6 hours as required. But something that I've started to do quite recently is put them on a continuous rate infusion at about 1 mg per kg per hour until they're happy and bright. All right. The emergency treatment, next one, that it's probably not familiar for a lot of you guys, is pimobendan. You do get an intravenous loading dose. It's not something that I use quite often, but there has its place. Something that I know, yeah, pimobendan, yeah, fantastic. Something that I know in Sri Lanka, especially when I was in uni, that people use, and even I'm sure a lot of the vets still use, is digoxin. I'll explain as to why that there isn't a place for digoxin in acute treatment of these patients. Fluid therapy, I have an IV line going at a very, very slow rate just to maintain an IV line. I do get my nurses to monitor dehydration quite regularly, monitor the urine output. I always have a big bowl of water in there because they're pretty good. They feel quite thirsty. So if anyone's ever had furosemide tablets, which I've tried once, you know how much of a thirst you feel within the effective period. Chronic treatment. So if you remember the chart that I showed you, the vicious cycle, the chronic treatment with these patients are always looked at in these 4 avenues. So, your inotropic effects. Inotrope basically means you're increasing your cardiac contractility. Loop diuretic, your furosemide that you would use. ACE inhibitor, that's more focused on your renin-angiotensin-aldosterone system suppression. Miscellaneous, you have digoxin, spironolactone, sildenafil, etc., depending on what's needed. But, the triple therapy that people always has to remember are the 1, 2, and 3s mentioned here. All right, so I do have a case that we'll try to work together, and this is one that has cough as well, and this is a bit of an interesting one. I've probably come to the previous X-ray to show you what you guys mixed as well. Any other treatment to calm down in the acute phase? Good one. I have access to butorphanol. I usually start them on 0.1 to 0.2 mg per kg. You can use acepromazine at a very low dose. So I use either 0.005 to 0.001 mg per kg. I sometimes use stuff like gabapentin to calm them down. I sometimes use trazodone, which I think is available in Sri Lanka now, if anyone can confirm. So those are my ones to calm them down. Have I ever had to anesthetize them? Few times, but I've had the luxury of putting them on a ventilator or getting one of the owners or the nurses to breathe for them until the congestive heart failure is addressed. And if I do that, I usually put them on a propofol CRI. So I'm just going to have a quick drink of water. Okay. Case 3. So we do have a 9-year-old male neutered terrier mix. History, there is a long history of a left-sided murmur. Classification, I didn't have enough information about what the classification was. Patient's not on any treatment at the moment. Presenting complaint was a cough that lasted for a good 3 to 4 months. On examination, you have your quite bright and happy, pink mucosa, CRT is good, heart rate is 120. A holosystolic 3 to 6 murmur. Holosystolic basically means I can hear the murmur all the way from the end of the systole all the way to the diastolic. So between S1 and S2, I hear the entire murmur. It's not a gap between the two. Again, left apical. Respiratory rate was hard to assess because this doggy was quite nervous and unhappy being a small little terrier dog. Tracheal sensitivity was negative. And the pulse was quite strong and regular. All right, so what would you do as your first diagnostic if you had this patient? What would you do in a clinical setting? You have a dog who's coughing, thoracic radiographs. Yeah, absolutely. I'll show you one first. What do you, yeah, radiograph, wonderful. So one thing that I did notice on this radiograph is if you look carefully, again, I do apologize about the quality of the x-rays, so you'll have to trust me on this one. So this is where your 9th rib is, and if you look carefully, you can see that your pulmonary vein, which is on the caudal side of things, is a little bit more distended and bigger than your pulmonary artery counterpart. And same on the other side as well. Again, I do apologize, so you do have to believe me on that one. So what does that mean? Anyone? Well, to me, it basically means that where there is certain degree of early left-sided heart disease that's going on. So I shouldn't be worried about the heart. All right, this is the right lateral X-ray. What do we notice? You do have your tracheal elevation. You do have your left atrial enlargement that is nice and clear here. You have your left ventricle slightly enlarged, right ventricle, you can see it touching your vertebrae quite a lot. I don't see any right atrial enlargement. All right, so what do you think causes, so working together, we do have an ulterior miss, a long-standing murmur, cardiomegaly, venous congestion, and a cough. So what condition would you worry about in older small breed dogs who has a loud murmur and who is coughing? We've discussed it before. What condition would you think is going on? Or what would you be worried about is a better question. So we have an older terrier mix, a long-standing murmur, there's cardiomegaly, venous congestion, and a cough. Mitral valve disease. Mitral valve disease is insufficiency is an inherent condition. It's wrong to say mitral valve disease as a cause of cough. There's something that happens secondary to mitral valve disease that causes cough. I would be saying congestive heart failure. Like, you know, you do have an older terrier mix, you have a long-standing murmur, you have signs of cardiomegaly, there is signs of venous congestion. Why would it be causing a cough? You know, you would be worried about congestive heart failure. It's a matter of confirming if that's the case or not. But, so, sorry, one thing that I want you to isolate yourself from is don't think it as for our patient specific. I'm just asking in general, what would you worry about if it is an older terrier small breed dog has these signs? You know, you want to worry about congestive heart failure. But the question comes, is it true for our patient? Did we see signs of congestive heart failure? Yes or no? Put a Y for a yes and an N for a no with people. I'll have this as a bit of a trigger. Do you want to look at the x-rays again? I'll go back to looking at the x-ray. Yeah, so that'll be your good x-ray to decide, do we have signs of congestive heart failure? No one? Yes or no? So what? Yes, and you think it's in C? Okay, we've got one answer from. Yes, you'd be worried about, so you'll be worried about congestive heart failure, okay. Yes, anyone else? It's okay to be wrong or right. No, okay. Yeah, I would agree with no, because I don't see signs of, no signs in the lungs. Yeah, very good. I don't see signs of congestive heart failure, especially in the lungs. I do have pulmonary congestion, but just because I have pulmonary congestion doesn't mean I have congestive heart failure. So it's a systematic issue that happens. You do have your So in classification, this one is actually in B2 and not C, because we're not seeing signs of congestive heart failure. All right, next question. Why do you think a dog is coughing? Anyone? I'll kind of explain to this, because this is something that I used to miss as well. So if you look at this X-ray, you'll notice that you do have the trachea coming in. And I should have had a comparative X-ray for this one, but your trachea at your carina, which is a crown, divides into your left and right mainstem bronchi. One thing that you notice here is that your mainstem bronchi is quite narrow. It's almost as small as the rest of the bronchi and bronchioles, so the bronchi. Like it's actually smaller than this big cranial lobe bronchi that's happening. The mainstem bronchi is quite small. One of the common misconceptions that people do have is that left atrial enlargement or having left congestive heart failure is enough of a reason to compress on the mainstem bronchi, which is, yes, I do have Dr. Chandika already saying that the enlarged left atrium touching the bronchi. So this is where the misconception is there, that the left atrial enlargement or the left congestive heart failure actually don't cause this compression by itself. The enlargement is not strong enough to compress on a strong cartilage. But then what would cause a compression of the cartilage? It's similar to what happens with tracheal collapse in dogs. So it's instead of calling it tracheal collapsing, it's what we call as a condition of bronchomalacia. Basically means weak cartilage. And if I'll probably go back to that in the question sections, I think. But it is, yeah, so it is mainly, this dog is mainly coughing because of bronchomalacia as opposed to congestive heart failure. But yes, being the small breed dog it is, you should worry about congestive heart failure. If I go back to the previous X-ray, you do notice signs of tracheal compression as well. If you look at the inlet here to the thoracic inlet, you do notice that your nice diameter that you see here is compressed. So this is where looking at an X-ray as a whole is important. Every chest X-ray that you do has to include your thoracic inlet, has to include part of your stomach and your liver. So this dog is on its way heading towards complete, tracheal collapsing down the line. But what's causing the cough now is actually this bronchomalacia that's happening here. Good. Okay, moving on. So this is diagnosing bronchomalacia. In a lot of the general practice, which I think a lot of people is based on assumption. You'll be quite lucky if you do see these radiographic changes of bronchial compression. I'm kind of lucky because I'll answer that question just in a second. So advanced diagnostics, you can either use CT scan, fluoroscopy. I don't have access to CT scan, but I do have access to fluoroscopy and bronchoscopy. So this is actually on the right side, is you can see how much it's compressed, and you can see how the blood vessels are a lot more congested and enlarged. And on the left side is a normal, a trachea going in. So that's quite a nice looking opening as compared to this one. So there's a question: pathophysiology of cough during congestive heart failure is due to just bronchomalacia? Okay, so yes, there is. So a lot of the small breed dogs, if you notice, are the ones who tend to have coughing compared to your Dobermans or your boxers. That's something to note when you're in, and a lot of them, especially given the age, do have a tendency to have bronchomalacia or tracheal collapsing. So yes, their cough is most likely related to that one. I'm not sure whether a lot of people know, but a lot of the cough receptors are not found in the distal bronchi and bronchioles. So a lot of your congestive heart failure signs affects your bronchi and bronchioles, not your mainstem bronchus or your trachea. So if they are coughing, it has to sensitize the cough receptors that are found on the trachea or the mainstem bronchi rather. So that commonly happens because they already have signs of bronchomalacia. So treating congestive heart failure in these cases alone wouldn't get you out of the cough. And if you think of cases that you've had, you'll probably remember a few cases where the cough really didn't disappear just by treating the congestive heart failure. Okay, so treating bronchomalacia, there's nothing that you can do to reverse it or tracheal collapse because they usually work together. My go-to treatment, weight loss is a key. A lot of the patients that I see, especially the cavaliers, are on the chubby side of things. I switch them always from a harness where the pressure comes on the chest rather than the neck, or choke chains. That's a big no. Bronchodilators, controversial. I never believe in bronchodilators. I know a lot of people do use aminophylline, theophylline. Corticosteroids, I do use them, especially short courses of them. And the biggest one that I use is codeine. It's a controlled drug in Australia, so I have to be quite careful when I dispense them. I usually start them off at about 1 to 2 mg per kg twice a day, and I do have a few patients who are at the high dose 3 times a day. They're a little bit sleepy and a little bit lethargic, but they're not coughing and upset. All right, out of these 5, what do you think are the most important treatment early on for better outcomes? 1, 2, 3, 4, 5, or a combination? Yeah, my go-to ones are basically weight loss and harness. Or yeah, but weight loss has proven to show the biggest impact in reducing clinical signs. Combined with rest, I think it's going to be a hard one to rest these small breed dogs. I know as much as you'd want them to be resting, they don't really rest. So my go-to most crucial therapy that I find, and I think a lot of people would agree, would be weight loss. It has a huge impact on your necessity for how much of pressure you need to breathe. It has an effect on how much your heart needs to work. All right, so going into more of the theory part a little bit, and I do find these a little bit interesting. There is 5 different types of cardiomyopathies that are broadly broken down to. So you do have your hypertrophic cardiomyopathy, dilated cardiomyopathy, arrhythmogenic right ventricular cardiomyopathy, restrictive cardiomyopathy, and unclassified cardiomyopathies. I've never diagnosed the last 2, so I think my focus is going to be on the first 3 only. All right, hypertrophic cardiomyopathy. Target groups, cats. I've never seen it in a dog. I used to work with a specialist in Sydney Uni who's only seen it in 1 in his 15-year career. So I'm pretty sure you don't have to worry about seeing them. It is the most common feline cardiac disease, up to 68% of all disease all heart disease in cats. The cats, you do have restrictive cardiomyopathy and dilated cardiomyopathy in smaller frequencies, but I probably have only seen very few cases of DCM. Restricted cardiomyopathy is very rare. I've almost never seen it, and I do see HCM cases quite more commonly. This is a bit of an interesting fact that I found while I was preparing for the presentation. I call it the case of El Blanco, which is a particular cat. Before the 1990s, the most common heart disease in cats was actually dilated cardiomyopathy, and it wasn't hypertrophic cardiomyopathy. The interesting was there was a particular cardiology specialist in the name of Paul in the US, and he had a case, El Blanco, that came in with dilated cardiomyopathy. As an incidental finding, he did notice that there was a small patch on the back of the eye. Him being a cardiologist and not an ophthalmologist, he didn't pay much attention to it. El Blanco's owners were quite devastated and wanted to know what the hell was going on. Why did my cat have to die, and why did it happen? So over the next few years, interestingly, Paul, the cardiologist, saw a few cases of dilated cardiomyopathy in cats, and all of them had this abnormal spot in their eyes. They also had one extra thing in common between these cats that he saw. They were all on a particular diet called Hill CD. If people must be knowing, it's for specifically for the fluted cats who have urinary issues, and it was known to be quite deficient in taurine as an amino acid. At the same time, University of California, Davis was conducting a research on taurine deficiency, and they had a few group of, I think about 11 cats in total, yes, 11 cats in total that had signs of, I was on a special diet that was restrictive of taurine. They reached out to Paul and were like, oh, we're about to put them back on the diet, the normal diet again. Do you want to come and do an echocardiogram? And interestingly, 2 out of the 11 cats showed, early signs of dilated cardiomyopathy. Best news was that this was a reversible condition. So poor El Blanco had to suffer, but if you go on, I should have asked that question afterwards, but yeah. So the best news was that if they go back on a regular diet that are fortified in taurine, DCM was unheard of. So a lot of the diets that's available now, if you look carefully, is fortified with taurine. You do have taurine added into them. And interestingly, if you do have diets, or if you do have cases where you do see dilated cardiomyopathy in patients of your own, one thing to look for is the diet good enough in taurine? The eye issue was actually later on or diagnosed to be feline central retinal degeneration. Completely different discussion, but I thought that was quite an interesting case. All right, hypertrophic cardiomyopathy in cats is a primary heart disease. They're genetically prone to it. They have what we call as concentric hypertrophy as opposed to eccentric hypertrophy. I'll show you a picture of what concentric hypertrophy looks like. And it almost always affects the left ventricle and the interventricular septum walls. You do have cases in cats where there is secondary thickening that happens because of hypothyroidism, hypertension, aortic stenosis. They look and behave like HCM, but they're not considered HCM because they're not a primary heart disease. So HCM is always a primary heart disease. So this is a picture that I've stolen from one of the textbooks, where you can see how much this left ventricle wall is thickened up and how tiny that left ventricular cavity is. And that's your interventricular septum, and it's so much, it's pushing so much pressure on that right ventricular wall. So basically what happens in hypertrophic cardiomyopathy at a cellular level is it's a problem of your sarcomeres and your arrangement of your muscle fibers. If anybody remembers your anatomy and histology, you do know that muscles are nicely arranged, but in hypertrophic cardiomyopathy, they're just all over the place, just arranged in different directions. That's basically what happens. All right, so it's an autosomal dominant disease. If you ever know a patient that has hypertrophic cardiomyopathy, you have to be very careful with your breathing regimens. I'm not going to worry too much on this side of these, but something that you have to remember is males are overrepresented. My experience, I've only seen males. Breeds that I see here are Maine Coon, sorry, not Maine Soon, ragdolls, but there you probably see Persians, Siberians, and British short hairs. I've seen a few of them in my last visit to Sri Lanka. But domestic horsehair or typical Valpusa will be the most common that I see. And honestly, that's what I see here, the domestic short-haired cats. They're easily missed because people don't look for it. The highest demography at GP practices. All right. Problem with hypertrophic cardiomyopathy that I have as a GP vet is that they're often asymptomatic until they go into congestive heart failure. So a lot of the times when anybody diagnoses them, they are in congestive heart failure. They almost never have a murmur. If you don't listen carefully, they can have a very soft murmur. But if you what they'll often have is a gallop rhythm. They'll have this S3 on a routine exam. They often present too late, and when I, as an emergency clinician, see them, I almost see them either in congestive heart failure or when they're in systemic arterial thromboembolism, or what I call as a fade cat. Prognosis in my experience is I've never had good response with fade cats. They've either come later on in life to be euthanized, or they've been euthanized on the day when they're presented. And this is quite sad because the cat usually is doing fine until this clot is dislodged from their hearts. So this is a dissection image of what the clot looks like. That's your aorta coming in, dividing into your left and right main vessels that goes to the back legs, and that's a tail artery there that goes to the tail coccygeal artery. So clot forms, and this is what we call as a saddle thrombus, if people remember. All right, pathophysiology. Basically what happens is you have primary thickening of the left ventricle and interventricular septum. You have very stiff ventricles. They're not able to contract well. If they can't contract, it retains, your afterload increases, so you have a very high diastolic pressure. Then you push back more blood up, or doesn't necessarily push back blood upwards, but it prevents blood from coming in, which means there is more blood remaining if your left atrium, causes eccentric hypertrophy, which is different to your concentric. And then you have congestive heart failure and signs of fate. Diagnosis. Every time you have a CAD, look for the subtle signs of, consistent tachycardias, murmurs, gallop rhythms, any signs of arrhythmias or pulse deficits. So those are the ones to look out for. Gold standard of diagnosis is echocardiography. I'm not going to talk too much on that one today, but the go-to measurement that you have to remember are left wall thickness greater than 6 millimeters, left atrial dilation more than 17 millimeters. Diastolic impairment is a specific way of doing your echocardiography measurements. I do not know how to do it, and I don't worry about it. Other things that you can do, electrocardiography, I've never diagnosed it with that. Chest x-rays only to confirm congestive heart failure. You can't confirm hypertrophic cardiomyopathy, because if you go back to your image here, your actual wall doesn't expand beyond, it only thickens internally. What about resting respiratory rate? Resting respiratory rate is only important if there is congestive heart failure. So if there are congestive heart failure, if they have signs of congestive heart failure, their resting respiratory rate will increase. Just to clarify what resting respiratory rate is, it's basically your respiratory rate when your patient is sleeping. That's my go-to measurement. So I get my owners to monitor how many breaths they take in a minute when their cat or dog is sleeping. I mentioned NT-proBNP, cardiac troponin 1, electrolyte abnormalities. I don't tend to use this as often, as I know a lot of Sri Lankan vets like using it. I don't tend to use them, so I haven't noticed much of an importance with that, with relation to hypertrophic cardiomyopathy. Okay, sorry, that's the same one I skipped. Okay, so this is an X-ray of a cat who has hypertrophic cardiomyopathy, but what's going on? What can you notice? I'll ask the question a little bit more directly, in a sense. What is something that you notice, or what is something that is related to congestive heart failure that you see in cats, but very, very, very rarely in dogs? Pleural effusion, yeah, fantastic. Pleural effusion is one of those things that you almost always see with congestive heart failure in cats that I never see in dogs. I've probably never seen it in dogs. Okay, if you've got pleural effusion, your cardiac silhouette is not visible at all. Your trachea is elevated. Our lung lobes are pushed towards the cranial side, and they are quite, small, and you can actually see the different lobes. You can see your cranial, middle, and caudal lung lobes. Yeah. Again, pleural effusion, that's around this X-ray. But interestingly, you don't notice pulmonary congestion, but you tend to see, you sometimes do see pleural effusion before pulmonary congestion, or alveolar, like or interstitial alveolar pattern. So that's something to remember. If you do have a cat who's got pleural effusion, if it's a modified transudate on your examination, try to listen to see if you can hear a murmur, look at the heart rates, etc. All right, treating congestive heart failure is pretty much what I've discussed before. Oxygen furosemide ACE inhibitors are your go-to treatment with congestive heart failures when related to hypertrophic cardiomyopathy. Why pimobendan isn't used? It's a bit of a hard one to explain on a discussion like this because it's a lecture one or lecture by itself. So you almost always have to do an echocardiogram to ensure that they don't have what they call as left ventricular outflow tract obstruction, or LVOT for short. It's very specific, and it's easy for a person who does it a lot to diagnose, but if you don't know, you shouldn't use any inotropic drugs in these patients. So oxygen, furosemide, ACE inhibitors are your treatment for congestive heart failure. Also, just a reminder, if you do have any questions, just don't hesitate to ask. All right, so we've discussed before about using pimobendan in dogs to prevent signs of their myxomatous mitral valve disease. But what do you do when you have an asymptomatic cat? It's a very, very hard one, and there is no perfect answer. So a lot of the times, if you look at the graph, and I've stolen this from one of the cardiologists, is the cardiac performance doesn't really decrease enough to cause congestive heart failure until, for a very, very long time, until the heart really fails. So a lot of the drugs that you use don't really have much of the effect on increasing the effects on preventing or delaying congestive heart failure in this cat. So treatment for asymptomatic cat, there is so much of controversial debates about it. Some people use ACE inhibitors, there's no evidence. Like I've quoted some of the journal articles here. Some people tried using calcium channel blockers, like a diltiazem, conflicting results. Pimobendan, no evidence, at least. It's why I say it's well tolerated is because of when they've done it in patients where the left ventricular outflow tract obstruction isn't there, so they do use pimobendan in those cases. Spironolactone, which is a potassium-sparing diuretic, no evidence. Thromboprophylaxis, that's more to prevent from the feline aortic thromboembolism happening or fate happening. Again, no evidence to prove. So if you do hear a heart murmur, if you do have an HCM patient, what treatment do you use to prevent any signs of it? There is no right answer. There is an interesting video. I had this cat over the weekend on the 12th. So before I show this to you, a lot of the times what happens is when your heart's contracting and when it pushes a clot, the best way for the clot to go is to your back legs. 99% of the patients that I see are always paralytic either on one back leg or both back legs, because that's where the clot likes to go. But this is one of the interesting cases that I had over the weekend, where the cat, if you can notice, is not wanting to bear weight on that right leg. Sorry, I don't have a long video of this one, but if you look, the right leg is limping on this. So on presentation, I did hear a heart murmur, older cat, cold extremities, etc. I should have asked the question, but so there's one way of diagnosing whether it is a fate cat, whether there is actually signs of a clot in the system. I do have access to ultrasound, so if I ever do have a worry of is it because of a clot, I always put an ultrasound probe on the abdomen, look at the aorta, see if there is a clot. But when it's your front leg, there is no obvious vessel that you can scan. But this study did where they compared the glucose levels of the ear tip or jugular vein to the tip of the affected leg. So you take a blood drop from your affected leg, So you can take it from the paw pad, a nail bed, and then you also compare it with like a jugular blood. If you do have your glucose level difference more than 2 millimoles per liter, or depending on the machine, 36 moles per deciliter, it's almost pathognomonic that you do have a fake patient. So the patient that I had there, so this was the jugular blood, 8.1 millimoles per liter, and you can trust me, you can see the 12 of the 6th, so it was last weekend. And then, you know, we can look at the timing as well, so 255 as opposed to 251, and the nail bleed. So there is a good, you know, differentiation in the glucose level. So this was from the nail bed and this was from the jugular. So, and the poor cat was put to sleep afterwards. How do you treat a fate cat where you have a thromboembolic patient? They're almost prognosis-wise, they're quite poor. Poor to 0 patient survival rate. It's very much anecdotal and personal experience. If you do want to go ahead, if you're against euthanasia, if the client's against euthanasia, you do have to go on strong painkillers. I have the luxury of opioids, and I almost always put them on opioids, but every time I've had someone oppose against euthanizing them, I've always had them come in a day or 2 later to be put to sleep. One thing to not forget is if you are treating these patients, they might be having congestive heart failure to some degree. Do your chest x-rays to see if there's any signs of it, because you'll need to start treating that as well. The treatment options that you have are either aspirin, clopidogrel, or a combination of the 2. So there is a study that was finished quite recently called the FATCAT study. It stands for feline arterial thromboembolism, clopidogrel versus aspirin trial. Only 15% of the cats that was in that trial were known to have some degree of heart disease. You can see how rarely it's diagnosed and how it's easily missed. But what they found was using clopidogrel as opposed to aspirin had better, as it significantly reduces the likelihood of recurrence. So one thing that you have to remember is if this happens once, there is almost always a chance. If I ever have to use it, I almost always use it in combination, clopidogrel and aspirin together. Any questions? All right, so coming to its canine dilative cardiomyopathy, something that I'm sure everybody's seen at some point, or DCM, as I would probably call it. It is, again, a primary cardiac disease. People do not know exactly why it happens and how it's happened, but there is breed predilections. It's characterized by, you know, as the name implies, cardiac enlargement and impairs systolic function. So it literally can't contract enough to push stuff outwards. So something that you have to remember and not confuse is your cardiac enlargement secondary to mitral valve disease is not the same as dilative cardiomyopathy. So what myxomatous mitral valve disease causes is cardiac enlargement is related to eccentric hypertrophy and related congestive heart failure, but DCM is a primary disease. It's not something that is caused by mitral valve issues. So this is commonly seen in medium to large breed dogs. Dobermans is poster child. Great Danes and Irish Wolfhounds. I'm not sure whether you have any Irish Wolfhounds in Sri Lanka, but I do see them here. And that's the heart of a Doberman that's had dilated cardiomyopathy. You can see how thin the muscle layers are, quite enlarged, cavities, quite thinned out. How are we doing for time? Am I still good to go ahead?
Yeah, Dr. Senra, you can go ahead.
Yeah, okay. So DCM is a primary cardiac disease. There is basically divided into what they call the asymptomatic phase, where you'll hear something like a murmur, see signs of enlargement on x-rays, and then you have the symptomatic phase where a lot of them gets diagnosed. So physical exam, a lot of these asymptomatic patients are normal. You might hear a murmur, radiograph subtle to almost no signs, because you don't always see obvious enlargement until they go into symptomatic phases. Oops. Sorry. ECG, a lot of them do have normal when they're in an asymptomatic phase. So if you do have, you know, medium to large breed dogs, even Labradors, I end up sending pimabentan to one of the patients from PetVet who likely has DCM in a Labrador. who's responding well to pimobendan. So, don't forget to look at your medium to large breed dogs, everyone you have. Signs symptomatic. Okay. Symptomatic, you do have signs of congestive heart failure, tachyarrhythmias, pulse deficits. Rarely you'll see right-sided heart failure, so you'll see signs of hepatomegaly, ascites, jugular pulses, etc. I mean, it's mentioned as rarely, but I remember seeing a lot of these Dobermans having signs of hepatomegaly and ascites. And on radiographs, you do see signs of congestive heart failure. On ECGs, you see tachyarrhythmias and sinus tachycardias. All right, what's the abnormality that you see here? Anyone? Yeah, there's an obvious BPC right here. Anything else? I should have given you the measurements on this one, but if anyone dare to answer? So the classical VPC that you see with ventricular tachycardia is this one, but this by itself is also a VPC. As you can see how different it is to a QRS complex. One thing that you notice with these patients is they tend to have quite tall R waves, and they also tend to have quite tall P waves. So those are your VPCs, and that's your tall QRS complex, and then your tall P waves. All right, so this is what an X-ray of, I think it was a Doberman, I can't remember exactly. Again, you'll see signs of left atrial enlargement here, which is quite obvious. You've seen signs of congestive heart failure that's going on. You look at your pulmonary, they're not as big as I thought it would be, but you do see signs of tracheal elevation, etc. One thing that I do like to do this in patients in these guys is to always send them to an echocardiogram, because you need to know your fractional shortening, etc. You want to know how badly dilated they are, and you'll always see the systolic. And one of the prognostic factors is if you do have diastolic dysfunction, that is a very, very poor prognostic indication. So I think I'm not going to worry too much about the echocardiogram because I know there's a lecture on that later on in the lecture series. Okay, so this is a video that I have. So you can see the quite enlarged left atrium, the very thin muscles that's going on in the left ventricle. And then this is, you can see again quite thinned out muscles and enlarged left ventricular cavity. And you can see the systolic failure, I'll show that again, where it doesn't compress as much as it should. So, I mean, for people who have seen enough echocardiograms, they can clearly see that this is not properly contracting enough to push decent amount of blood out. So they're in systolic dysfunction at this time. Good. So in asymptomatic stages, there is certain early studies that show that there is going to be some beneficial to using pimobendan. This is a good candidate where if you suspect DCM to do your NT-proBNPs, that will show you some elevations. ACE inhibitors has a moderate degree of effect. And sotalol and mexiletine are basically used to suppress ventricular arrhythmias. So in a lot of the symptomatic patients that I've seen, your treatment, you're basically has oxygen, strict rest, furosemide, pimobendan. Lignocaine I use intravenously when you have severe ventricular tachycardia like these until it's controlled. I put them on CRIs or boluses. And if you do see, signs of pleural effusion or severe ascites, manual removal will help their breathing quite a bit. The acute ones, again, if you do have ventricular tachycardia, sorry, this has to be more chronic treatment rather. I'll correct that on the final one. There is evidence to use sotalol, mexiletine, and amiodarone. You use, in sequence, I use sotalol. If it's not addressed, then I use mexiletine in combo. If that doesn't work, I use amiodarone. I don't have a lot of Dobermans in Australia, so I don't tend to use these drugs as often, but it's something to look at. If you do have signs of atrial fibrillation, that's where your digoxin and diltiazem comes into play. All right, so arrhythmogenic right ventricular cardiomyopathy, or also known as boxer cardiomyopathy, because I've only seen it in boxers, and that's what they call. Bit of a, so boxers dogs are overrepresented. Something that you shouldn't forget is boxers also get DCM, so it's important to confirm which one it is. One of the common presentations that you see in these guys is signs of syncope, collapsing, and sudden death. I've had probably 2 boxers in the last year that called me during emergency hours saying they fainted, but when they came in, they were dead. And the only, I had to kind of assume that it was ARVC because I didn't see any signs of dilated cardiomyopathy on post-mortem. It happens because of the pathophysiology. Basically, they do have this fibrofatty infiltration that happens specifically into the right ventricle. So if you look at these images, you can see the amount of fat that's in that right ventricle as opposed to a more normal looking one. You can see how the muscles, if you do a cross section, they don't look as nice and thick and like you normally should. And again here as well. All right, so one of the things that are like a pathognomonic ECG lesion that they see is you see this upright VPCs that happen from time to time. Some of them, if you're lucky, you'll see them. Sometimes you do have to have an ECG monitor going on for quite a bit of time to see these upright VPCs if you're unlucky. So the way a lot of the times when they come into my clinic in an emergency setting, I do see the ventricular tachyarrhythmias rather than ventricular tachycardia. So this is where they'll have a massive heart rate, really high heart rate, where you do see ventricular premature complexes. Non-clinical ARVC is you do have to listen to their heart rhythm quite closely at each exam. You might, if you're lucky, again, you might notice this occasional extra beat. If you do hear an occasional extra beat, that is an indication to put the ECG on. You might be lucky to see a VPC. How specialists do monitor is they fit this, what they call as a Holter monitor, onto them that records the reading for quite a long time, and then they'll get this chart and they can put it into a software. The software detects these upright VPCs and tells them when it's happened. So interestingly, in this patient, when this happened, was the owner was driving the dog home and he wasn't looking front really well. A car cut in front of him and he hit the brakes. So that excitement caused these VPCs and the arrhythmia to show. So the owners are usually asked to keep a log on, what stimulatory activity that's happened. Okay, so again, not a lot you can do to prevent them. It's more so being aware that they will go into congestive heart failure, and if that happens, femobendin furosemide ACE inhibitors to basically treat your congestive heart failure. Sotalol, mexiletine, and amiodarone does have effects. Fish oil, interestingly, there is a study that showed that when you give it for a good 6 weeks, that it did help to reduce the VPC numbers, but later studies have shown that it's not enough to warrant treatment. But I usually put them on fish oils just because no apparent reason. It's not harmful, so why not? All right, so this is kind of the last part of the lecture where I kind of want to emphasize a few things. Number one, pimobendin. Is it available in Sri Lanka or not yet? If anyone can type in. But anyway, so it is the only positive inotrope drug that is recommended to be used in dogs. We are in dogs and cats. We are lucky in the veterinary world because we do have this drug. You don't have a counterpart in human medication that does the same effect of inotropic effect that the pimobendin does in people. Still not commercially available. Yeah. So it's good to treat clinical heart disease that I've discussed before, and I always use this in treating congestive heart failure, dilated cardiomyopathy. Other effects, they do have a negative chronotropic effect, so it does reduce the heart rate, so reducing the heart's fatiguing. It does have a good vasodilatory effect, which you positive vasodilatory effects on both arterial and venous dilation, which is fantastic effects that it has. It's not indicated in HCM or aortic stenosis. Interestingly, who knows me, I do have a golden retriever of 4 years. She does have subaortic stenosis, and I should be careful never to use pimobendan. But she's in a subclinical stage, so I don't use any drugs on her. Digoxin, the drug that is ingrained into our Sri Lankan vets' minds as students, that has fantastic inotropic effect, but sadly that's been proven multiple times to be absolutely of no use as an inotropic drug. So if you do have a congestive heart failure patient, using digoxin is of no use. The risk of toxicity outweigh the benefits, and it's very much contraindicated in renal patients. So if you want to look at this study, and I can send you the article as well if you would like to. It does have a certain degree of inotropic effects, but it's not warranted to be treating for congestive heart failure. The only place where digoxin has its place is treating atrial fibrillation. So do I ever use it? Like I said, the only time I ever use it is atrial fibrillation or supraventricular tachycardia. So if you look at this, you do see these extra P waves that's happening. So that's supraventricular tachycardia that's going on. I've said once or twice a year, but honestly, I haven't used it in the last 2 years. ACE inhibitors. So your enalapril, I have benazepril, one of the other prils, all the prils does have its place. So they did this study called the they did this called the Quest study, where they compared use of pimobendan versus benazepril only to treat congestive heart failure. As you can see, the long-term survival rate of patients is kinda similar. Say, you do have 20% of the patients going up to about 650 days. But if you look at the curve, pimobendan does have its place more than benazepril. So this is my way of kinda wanting you guys to, try and look into pimobendan. I know it's available in India. I know you can get Indian-based ones, which are a lot cheaper than Cardisure or Betmedin that I use here in Australia. ACE inhibitors, they're primary renin-angiotensin-aldosterone system inhibitors, so they help with vasodilation, and they do have anti-hypertensive effect because they cause the vasodilation. I use them almost always in patients that are in stage C of heart disease. I don't use them in stage B2 because there isn't any effects of it. I've said enalapril because I know there isn't probably benazepril in Sri Lanka. Their all doses are 0.25 to 0.5 mg per kg once a day. One thing that you want to monitor in these guys is the sodium and potassium levels, urea and creatinine, especially if you're using enalapril, because it does. Enalapril is 100% kidney-related excretion, so it does have some kidney effects. Benazepril that I have here is 50-50 liver and kidney-related, so that's a little bit safer. Furosemide, you have to have it. Everybody knows about furosemide, hopefully. Spironolactone, again, something that I very rarely use. Its diuretic effect is almost negligible. I only use it as an adjunctive treatment. There is certain evidence to say that there is cardioprotective effects reported in these, but there is reports that both pro and debunk this. All right, that's my lecture. Thank you. I'm happy to answer any questions you may have. I'm happy for you to come away from your, you can unmute and ask as well.
Yeah, you can use the chat option of Zoom so that it will be easy for Dr. Senra to answer your questions.
Yeah, I'm more than happy to answer cardiology, surgery, ultrasonography questions, anything that you'd want to know. No one?
I have a comment kind of thing, Dr. Senra.
Yes.
So now in Sri Lanka, like at least in our practice, like about 25% of heart patients that I see.
Yeah.
Unfortunately, what I normally do in this 1/4 of heart patients is to stop all these heart medications that my colleagues have started.
Yeah.
So
Yeah.
it's a bit of a sensitive issue because I never criticize my colleagues in front of the client.
Yeah.
But at the same time, I have a ethical duty towards the patient and the client that I have to stop these medications also. And the majority of those cases, the colleagues, what they have done is they have not done any echocardiography or x-rays, only ECG, and they diagnose left ventricular enlargement from ECG and start on all these cocktail of heart medication. Would you please comment on this so that we can improve our...
Yeah, so ECG does have its place, but ECG is a bad instrument if you don't know what you're looking at, especially if you don't have all the information. If you look at any book, any even what I've recommended, ECG is down the list. ECG is never the first thing that you go to. If you don't have signs of congestive heart failure, if you don't have signs to prove on especially in small breed dogs where you're worried about mitral valve disease to show that they have heart enlargement or the left atrial aortic ratio, using heart medication can also be quite contra indicated, and they do have effects on other organs. So I'd never go based on an ECG, and I do agree, and I remember it's something that I do see when I used to work for a short period in Sri Lanka. Was there were times where I had, and I wasn't quite familiar with my cardiology then, but it didn't seem like it was needed. I hope I answered the question. Do your basics, do your chest X-rays, do your echocardiogram, refer to someone you know or someone who does them before you start on heart medication, especially something like digoxin. It's like I said, I wanted to bring the digoxin into the conversation, especially because how much it's ingrained into our minds, how the whole pros and cons of it. But as you can see, there's enough evidence to show that digoxin doesn't have much of a benefit as we thought it did.
And Dr. Senra, you do have a few questions in the chat box.
Yeah, okay. First of all, thank you for the insightful session. No, my pleasure. It was quite fun doing it. So I'm gladful that I got the opportunity. Can you please elaborate on treatment protocol for a kennel cough? Okay, kennel cough, I diagnose only by clinical signs. If you want to be pedantic and diagnose it, you can do a bronchoalveolar lavage, but I think that's going too far. Kennel cough treatment, it's similar to how I treat the cough patient. I start them on antibiotics. I see if there is any response to doxycycline. In a week later, if they do, I continue that one. If they don't, then I add steroids in. Prednisolone, I know I've said I go for 4 weeks, but kennel cough usually is an acute issue. I don't tend to go for 4 weeks. I just tend to go for about a week with steroids to reduce it. But doxycycline, I go for a minimum of 2 weeks. What about HCT, hydrochlorothiazide, instead of furosemide? Ooh, to be honest, I haven't used it, and I don't know anyone who uses it. Furosemide is cheap. Furosemide is known to be the most effective, and that's the one that I recommend. So I'm sorry, I don't know enough to tell you more about it. Furosemide, use what you know works. More thank yous. No, thanks for listening to me. Anything else? I'm more than happy to answer questions.
Yeah, if any participant want to ask live questions, I think now you can switch to live questions.
Yeah, there's 78 participants, which is fantastic.
There's another chat question, Dr. Senra.
Yeah, should you give enalapril only if blood pressure is high or when there is indication of pulmonary edema? If you actually have pulmonary edema, So enalapril has two functions, like I said. The main thing that it does is it inhibits your renin-angiotensin-aldosterone system. If you do have a patient who's in congestive heart failure, chances are they do have hypertension, almost always. So enalapril is always indicated. Even if not, I usually start them on a lower dose of enalapril. Because it does have certain protective or delaying effects of the progression rather coming into use. So I do use it at a lower dose. I'll probably use it at about 0.25 mg per kg if that's the case. But again, you do have to monitor your blood pressures. I think I do have a really good machine that does the NIBP. That machine was $10,000, which we just got. So that's about 15 million Sri Lankan rupees. That's a complete anesthetic monitoring machine that we've got to the clinic. That does very good NIBP measurements, but if not, Doppler measurements is the way to go. Don't trust your cheap $1,000, $2,000 human counterparts. Can I receive the PowerPoint? Yeah, I'll probably send it to Dr. Chandika or Dr. Sugat, and I think they'll be able to send it around. I'm more than happy to send it. Yeah.
Any other questions from the participants?
Even respiratory. Oh, love from Nepal. That's fantastic. Is measuring blood pressure reliable in patients? Of course, yes, yes. I can't emphasize how much it's not measured. Even in my practice, there's so many times where I've had to intervene and be like, did you measure the blood pressures and go about? And it's something that I do tend to miss as well. I've got, especially in an emergency setting, we do a lot of blood pressure measurements in my patients. And I work, 2 emergency shifts every week. So I do see a lot of patients that needs blood pressure measuring. How often or for how long can we use furosemide in a heart patient? Forever. You shouldn't stop them. All heart medications that you use are forever. You can titrate it downwards. So you can, if they're in congestive heart failure, you can start them at about 4 to 6 mg per kg, 2 to 3 times a day. But once the lungs have cleared out, you can bring them down to 2 mg per kg twice a day. As you can, I'm not sure whether you remembered, or furosemide, I'll go back. I sadly don't have it on this slide. So furosemide, furosemide basically has only a very short active period when you give it per orally. So you'll have to give it up to 3 times a day. Any questions from the lecture? Sorry, I'll share it again. That you wanted to ask. So one thing that I said I'll show you from the previous patient was, I'll just go back here, is you can ask any other questions while I navigate. So in this image, can you see it? So you can see how your mainstem bronchi are quite normal sized. You can see it's divided and they're much bigger than your normal ones. So on the other patient that I discussed later on, you can see how narrow that is. That's something to appreciate the next time you do x-rays. It's something that I didn't know until probably 1.5 years ago. It's something that I missed as well. So I have the luxury of referring cases and being proven that I'm wrong. I'll share my email address as well if people would want to send me cases. I love seeing other people's cases and helping out. So I'm more than happy to have a chat with anyone. Appreciate if you could unmute the camera to see me. Does anybody want to see me? I'm not sure. Yeah, anything else?
Dr. Chandika, any questions from the audience?
Yeah, it's time for you to ask live questions from Dr. Senura. If not, I have one last question.
Yeah, well, I'll answer that while we wait.
this is regarding the previous question, Dr. Senra. Like somebody asked, I can't remember the name of the doctor, about like putting enalapril when the blood pressure is normal.
Yep.
Can I bother you by asking you to go to the slide, the previous slide that you showed a vicious cycle, and explain it?
Yep.
Because that's, I think, is very, very relevant under Sri
Yeah.
Lankan veterinarians.
That's the one.
Yep.
So as you can see, this is, like I said, everything that I've explained today comes back to this cycle. I was initially, when I made the presentation, I had this slide repeating over and over again, but I thought it was too much. But basically, again, you know, your renin, this is where the renin-angiotensin aldosterone system and your sympathetic activity, that's where your enalapril specifically works. The sympathetic activity does two things. Number one, increases your heart rate. Number two, it does vasoconstriction. So your enalapril helps with vasodilation, and then it prevents, you know, reabsorbance of fluid and things like that. That can be detrimental to the cardiac patient.
Okay,
Anything
then
else? Yeah.
we don't have any more questions. Yeah, thank you very much, Dr. Senra, for this very, very informative and very like timely lecture and the discussion. And
No problem.
we are like awaiting to like participate to your next lecture in time to come. Thank you very much.
The next one's going to be a fun one. That's where my forte is. I do a lot of surgical oncology and skin flaps and things like that. So I'll be quite interested too. Yeah.
Okay, thank you very much, Dr. Senra. Thank you very much. On behalf of SLVA, I would like to really thank you. And also I would invite Dr. Sugat Pemachanda, the Secretary of SLVA, to do the formal vote of thanks.
Thank you very much, Dr. Chandika. Dr. Irandika Gunawardhan, the President of Sri Lanka Veterinary Association. Dr. Senura De Silva, resource person today. Dear doctors, ladies and gentlemen, on behalf of the 73rd Executive Committee, I take this opportunity to extend our most sincere gratitude to Dr. Senura De Silva, who accepted our invitation as resource person despite his busy schedule. We believe that the knowledge you have shared will help immensely in the improvement of skills of veterinary in Sri Lanka. We are grateful to Dr. Chandika Wickramasinghe for your special support to make this workshop a success as a moderator. And also I would like to thank all the doctors, the students who participated today to make this workshop a success. Thank you very much for all. Thank you.